Start by exploring what the Q-angle actually is and why it matters in clinical practice. The Q-angle or quadriceps angle is a measurement used to assess the alignment of the knee joint. It's defined by the angle formed between two imaginary lines, one from the anterior superior iliac spine (ASIS) of the pelvis to the center of the patella, and another from the tibial tubercle to the patella's center. This angle is thought to represent the force vector of the quadriceps and patellar tendons acting on the patella. Traditionally, clinicians have used the static Q-angle as a key parameter to evaluate knee alignment and predict risks for injuries like patellofemoral pain, patellar instability, and other knee disorders. However, the clinical value of the static Q-angle has been questioned due to its limitations and inconsistent correlation with actual knee pathology. As research has advanced, a new concept has emerged, the dynamic Q-angle, which considers knee alignment during movement, offering a more functional perspective on knee biomechanics. Now let's take a closer look at the static Q-angle and its limitations. Static Q-angle is measured while the patient is either standing or lying down, with the knee extended or slightly flexed. While this measurement is widely used, it has several drawbacks. First, the static Q-angle does not accurately reflect the true direction of quadricep muscle force during movement. The angle can vary significantly between individuals, and even between the left and right legs of the same person. Factors like gender, race, and anatomical differences such as pelvic width can influence the Q-angle. Moreover, there's a large overlap in Q-angle values between people with and without knee pain, making it difficult to set a clear threshold for what is considered abnormal. Most importantly, the static Q-angle fails to capture the dynamic changes that occur during activities like walking, running, or jumping, which are often when injuries happen. This has led researchers to question its clinical significance and seek more functional assessment tools. Shifting our focus to the dynamic Q-angle, we see a more functional approach to knee assessment. The dynamic Q-angle is measured during movement, such as squatting, walking, or jumping, and takes into account the complex interplay of hip, knee, and ankle mechanics. Unlike the static Q-angle, the dynamic version considers three key elements: the frontal plane hip adduction and knee abduction, the transverse plane hip internal rotation and tibia external rotation, and patella behavior. This comprehensive view helps clinicians better understand how the knee functions under real-life conditions. Studies have shown that dynamic Q-angle measurements, especially those assessing dynamic knee valgus (DKV), have higher reliability and better ability to differentiate between people with and without patellofemoral pain. However, measuring the dynamic Q-angle can be challenging, often requiring advanced motion analysis systems. Despite these challenges, dynamic assessments are gaining popularity for their clinical relevance and potential to guide injury prevention and rehabilitation. Summary: while the static Q-angle remains a common measurement in clinical settings, its limitations have become increasingly apparent. It does not reliably predict knee injuries or reflect the true biomechanics of the lower limb during activity. The dynamic Q-angle, particularly through the assessment of dynamic knee valgus, offers a more accurate and functional evaluation of knee alignment and risk factors for injury. Clinicians are encouraged to incorporate dynamic assessments into their practice, using accessible tools like smartphone apps when advanced equipment is not available. Ongoing research is needed to refine measurement techniques and establish normative values for dynamic Q-angle in different populations. Ultimately, a shift towards dynamic, movement-based evaluation will enhance our ability to prevent, diagnose, and treat knee injuries more effectively.